Today we'll be talking about atrial fibrillation. It is one of the most common sustained arrhythmias worldwide and presents very commonly in clinical practice. It is characterized by a hyperexcitability in the atrial tissue. This is due to the re-entrant circuits that are available in the atrial tissue. And this causes rapid firing and very large atrial rates reaching about 400 to 600. This actually causes a dysfunction of the atria, and because of the rapid rates, there is stasis of blood, and this causes clotting. Now you can see the clotting is very apparent in the atria right here, and it is also very apparent at somewhere called the left atrial appendage, and we'll talk about the clinical importance of this area later on. Now to differentiate atrial fibrillation on ECG, you want to look for three things. So it's actually memorized by the mnemonic NIP, which it stands for narrow QRS, irregular R-to-R interval, and also absent P waves. Now the risk factors associated with AF include advanced age and old people. So it's very common to get AF after the age of 70 years old. People with hypertension, cardiac disease, or diabetes, and other comorbidities, obesity and sedentary lifestyle, and use of recreational drugs and alcohol abuse. All of these risk factors were associated with AF, and it was thought that the pathophysiology of this condition was related to alterations in the ionic channels of cell membranes. This leads to fibrosis, and fibrous tissue then becomes hyperexcitable by forming re-entry circuits. Now you can see the difference anatomically between normal tissue and atrial fibrillation. You can see how there are re-entry circuits available, there's fibrosis, and all of this causes structural changes in dilatation of the left atrium, and stasis of blood occurs, of course. This condition is called stiffened left atrial syndrome. Now, for electrocardiophysiologists, there are certain areas of interest when dealing with atrial fibrillation. And you've got this region called the pulmonic vein musculature, or pulmonic vein sleeve. And this is that looking at the heart from the posterior aspect. This is the left atrium, this is the left atrial appendage we were talking about previously, and this is the left ventricle. And so 80% of the time the origin of the hyperexcitability is from here. So ablating these regions would treat most of conditions. Also near the superior vena cava sleeve, near the coronary sinus, and the remnant vein of Marshall is another target. Now, to classify AF, it is classified into different stages according to the burden of the fibrosis and the progression of the disease. The more the fibrosis and the structural changes, the less likely sinus rhythm is achievable, and treatment is less likely to work. So in conditions with paroxysmal AF, little fibrosis, maybe just in the beginning, episodes last less than 7 days, terminated by medical treatment or intervention, cardioversion. Sometimes it takes more than 7 days and reaches less than a year. This is called persistent AF. Long-standing AF is episodes that last more than 1 year. And permanent AF is an agreement between the doctor and the patient that sinus rhythm or rhythm control is not achievable, and they just remain on rate control treatment. And we'll talk about different treatment strategies, rhythm control, rate control, and ablation in a later video. There's also something called non-clinical AF, in which the abnormal contraction of the atria is present, but without the patient having symptoms, and this is called non-clinical AF. And this actually needs high surveillance, needs Holter studies, ECG studies, echocardiography to actually measure the diameters of the left atrium itself. And in these cases, you want to treat before apparent and frank AF to prevent the risk of thrombosis and stroke.